Good evening.
Hi Tejo, good evening. We are live. Okay, let's start.
Yes, sir.
All right, then I'll start then. Good evening, dear friends. It's with great pleasure that once again I extend a warm and heartfelt welcome to all of you for the second lecture in our series all about sepsis. As you all know, this is a comprehensive and timely course developed under our action plan, guided by our central theme, reaching the unreached. By now, after completing the first lecture, you would have realized that this course is reflecting our collective commitment uh, to empower all of us with up-to-date insights, sharpened clinical judgments, and practical tools to protect the lives of our most vulnerable patients. Through this course, once again, let me reiterate this point. We are going to learn when we should start antibiotics, when should they not be started, if necessarily, which antibiotic is most appropriate, why does it that withholding use of antibiotics sometimes yield better outcomes in NICUs, what are the proven strategies to prevent sepsis, because this is a game where sepsis is not like any other disease in neonatology. This is a dynamic game where we play along and the rules change as years pass by. So we need to be up to date. What are the evidence-based strategies, proven strategies to prevent sepsis? Prevention is probably the only thing that doesn't change, whereas the rules of management keeps changing every day. So that's why we need to be very careful. And how do we tackle the highly resistant infections, including fungal pathogens? And then lastly, how should we manage an outbreak effectively? All these things you will be learning. I would again request, we are happy to have such a huge number of great enthusiasm and huge number of delegates for this. I hope you are able to do the pre-test. We have lowered the requisites for the post-test so that you can go along, and please feel free to interact at every point, because the idea is at the completion of this course, said you should have a clear idea of how we should be managing sepsis. So I'll not waste any more time. And all these points I stressed in the last session also, but again I'm repeating. This is one of our what should I say, key action plans this year. So thank you for being part of this. I would request all of you to be to continue to be part of this till the end of the course. Do not drop out in between. If at all you happen to miss a lecture in between, it would be a big loss, because the live interactions are the way to go. But if at all you happen to miss, it is available in our NNF learning management LMS learning management system, where you need to do the pre-test to access the first module, and then after each module, the post-test for the next module. All right, with this introduction, now we are going to today going to have a great session on one of the common dilemmas that we face today. So that is diagnosis of sepsis, blood culture use, interpretation, use, misuse of biomarkers, etc., etc., etc. To tell us more about this, we have, and to moderate, steer us through this session, we have two great clinicians who will be moderating this session, Dr. Sujinta Mukherjee and Dr. Sunil Gavani. So I would straight away hand over the podium to them. Over to you, Sujinta and Sunil.
So, very good evening to all the participants, the organizer, and Dr. Naveen Jain. And it's my privilege because Dr. Naveen Jain doesn't require any introduction, but if we want to formally introduce him, Dr. Jain is a very eminent neonatologist, and he is the senior consultant at Kerala Institute of Medical Science. He is not only a good clinician, but as a renowned academician and a good researcher, and he has a lots of publication and authorship of very different types of books. And he has not very special interest on neurodevelopmental follow-up of NICU graduates. And always his lecture very impressive and enriched with recent updates. So today we are also looking forward to learn from him, from his lecture, the diagnosis of sepsis. And I think all the participants will learn the recent updates on diagnosis, and the very important is where to treat and where not to treat. We, without wasting much time, I will request my co-moderator, sir, to say a few words about this program and before starting the lecture by Dr. Jain. Thank you very much, sir.
Thank you, ma'am. Indeed, it's a pleasure and privilege to be part of this All About Sepsis module. Thank you, sir, Manoj, sir. And at the outset, I'll just request all the participants make use of this module maximum, because these are all practically designed. It will be useful for your day-to-day practice. And as sir said, I will just reiterate same thing. We can reduce how we can reduce the uses of antibiotic that we have to see. So how to interpret these blood cultures and biomarkers, which will help us to rational use of antibiotic, that we have to see first, and start at least the baby steps, so we can definitely decrease the incidence of sepsis and antibiotic uses also. Coming to today's topics about blood culture and biomarkers in the sepsis, common problem day to day in NICU. This is the most common problem we face. Interpretation of this thing, and today we have none other than Naveen Jain sir. Sir, like as a ma'am said, sir doesn't require introduction. For me, he's a great teacher, and looking at him, we grew and we learned neonatology from sir. So today I'm indeed like very happy and privileged to be part of this lecture series. I'm also looking like for this lecture. It's a great opportunity for me to learn from the Naveen sir again. So without wasting time, and again I will request all the participants to have it, make it more interactive, so that it will be more helpful also at the end. Thank you, Naveen sir. Over to you.
Thank you, Suchanda ma'am, Sunil, Abhi, and Manoj. And I won't go to any pleasantries because all the young people have been spending their evening on a Zoom meeting with us. Abhi, is the sound all right as you would like to hear it?
Yes, sir.
Yes.
Fine. It's right.
All right then. So, although we have made a disclaimer in the beginning that we'll attempt to avoid personal bias in the presentations, but I still feel that some element of personal practice and beliefs might creep in, and I'll be very happy to have confrontations or difference of opinions from each one of you because you all practice save sick babies and diligently use medications in saving babies. So if you have difference of opinions, be open to discuss at the end of the presentation. We're proud that the NNF has taken up a topic which is so important, is in management of infections in newborns. I think this is almost 80% of the work we do in everyday practice in the NICU. What we aim to do today is, do we have a method to diagnose infection as early as possible? Because we know clearly that this is life-saving and will prevent hospital stay, cost to patient, and long-term health also depends upon early diagnosis. In this attempt to make an early diagnosis and start antibiotics early, we are aware that we land up overdiagnosing infection for everything that we see as a symptom in the NICU. So is there a way to balance this early diagnosis against risk of over-treating babies with antibiotics? It is in this context we will see where does blood culture stand and what are sepsis biomarkers. With the belief that some of the people are residents in this group, I'll just mention what a biomarker is. A biomarker is a test or a clinical or radiological finding that is used to replace a gold standard. So here we will have to start with this premise that currently gold standard for diagnosis of infection is blood culture. What we are trying to see is any of the biomarkers can predict what the blood culture would be accurately, earlier, and at a lower cost maybe than blood culture can be. Like we already said that if you make an accurate diagnosis very early, it is going to improve clinical outcomes. A point of caution here is something we don't realize. You may take rounds and decide that an antibiotic decision is made, we may start antibiotics. I must confess, in a level 3B NICU, which as per NNF is one of the best accreditation of Indian NICUs, it may take sometimes 4 to 5 hours in a unit like mine between discussing on the bedside that this basic baby needs an antibiotics and finally the first shot of antibiotic going into the baby. I will urge each one of you to read an article in BMJ Quality by my teacher, Dr. Saurabh, where they tried to do a quality initiative in PGI to try and reduce the time between decision and antibiotic delivery to half an hour. So while you ask yourself, do I have a better test which will give me early diagnosis? Please also ask yourself that do you have processes in place that after you made a decision, whether you send a lab test or decide antibiotics, are they actually happening in time? We all want to reduce overuse of antibiotics. I think the direct harm which people don't realize is when you push a piperacillin, tiozobact, or amikacin antibiotic into the baby, that syringe pump may be carrying Acinetobacter from your unit, and a baby who did not have infection till now gets 3 opportunities a day to enter a baby's vein directly. So while you try to argue your way out saying that this is a sick baby, I cannot take a chance, antibiotics must be given, you don't realize that you're giving an opportunity to infect the baby several times a day. And the number of days that you place a cannula, replace a cannula, the risk of infection becomes manifold. By second, third day, the risk is exponential. And therefore, this is one disadvantage of overuse of antibiotics. Not discussing the cost of staying in hospital, the cost of nursing skills, syringe pumps, needles, infusion lines, and so on. Not just the antibiotic. Even in adult, broad-spectrum antibiotic for 5 days selects systemic fungal infections and multi-drug resistant bugs, which you will never be able to diagnose and treat. I think I have given enough reasons to discuss why we would like to reduce overuse of antibiotics. And there is an unsaid side effect which parents ask but we tend to overlook of antibiotics on growing organs like kidney, liver, and brain. These are also important. When we talk of taking blood culture, the first objection most people have that it is time consuming, the report would come only in 2-3 days, whereas I need to take a decision now. The second one is somehow the lab, the blood culture as a test seems to have failed our trust. There are babies who are sick looking, worsening right under our eyes, and the lab calls and says their culture is negative. Occasionally, a culture comes positive when you're planning to discharge a baby. Now you do not know what to do. So what can we do? Why is this discordance there between our gold standard and our practice? Because this is not available, the Darka business where you're scared, you want something to write on the paper, why did I start, why did I stop? You want somebody else to be blamed for your decision making. Therefore, biomarkers have become famous. I think it's totally blind faith. I will make an effort throughout the next 30 minutes to justify why most of the biomarkers available are merely shifting responsibility from clinical and judgment to lab to make a documentation, and really they are not helping us in making good decisions. I'm going to discuss a real life clinical scenario which everyone, not only Dr. Manoj and AB who manage intensive care babies, a 36-week baby is born, obstetrician decides to deliver early, 2.4 kilo baby, brought in with some tachypnea to an ICU. 4 hours have passed, you got 3 hours to stabilize the baby. You applied CPAP, started some IV fluids, but after 3 hours, when we do our popular stops, that is the primary survey for a baby, baby sensorium remains active, he is looking around, moving well. Temperature is having slightly cold peripheries, slightly dusky peripheries. Heater output of the machine is 30%, which is reasonably high after 4 hours of stabilization. Baby is on respiratory support of 6 PPAP with some retraction amount of oxygen. Perfusion is good, heart rates are good, refill time is good, sugars are normal. Now the questions are, should I start antibiotics in this baby or should I wait? I know most of you would have answered in your mind that lecture mein theek hai, real life mein I would have started antibiotics on this baby. Is blood culture helpful now? What will I go and tell the parents? Even if I send blood culture, reports are not going to come now. They will take 2 days. I need to know now. Else my decision is start antibiotics. What about CRP, CBC and chest X-ray? Chest X-ray in my unit would be available within 20 minutes. And while they're clicking, you can see the X-ray on the X-ray machine itself. So instant report. Most of us are experts in reading an X-ray for pneumonia. Blood count and CRP would be available before I go home or can be communicated on the phone to me, and I would be able to take decisions. Okay, let's say we trusted culture and we ascended. What do I do after culture report is available? If it is negative, what do I do? Can I stop bravely? Or if it is positive, shall I go further and change antibiotics? We'll touch upon some other biomarkers like procalcitonin. We have some personal experience in our own research. PCR, we have done almost 4 studies and 2 of them are published and 2 in pipeline. So we'll try and share what our learning experiences on these. And my DM thesis was on interleukin 6. So if somebody wishes to ask questions in the end, we will answer why we decided not to publish this paper and why we were disappointed with this biomarker also. So in this situation is clinical suspicion of sepsis. The baby is having respiratory distress, slightly cold peripheries. An algorithm which we proposed in the Cloharty's Southeast Asian edition, which is borrowed from standard literature, like NICE guidelines from the UK, is that even if one red flag sign is there, we must investigate, that is, send blood culture and start antibiotics. We'll come to the next slide and show you what is a red flag sign. If there are no red flag signs, but there are 2 clinical signs or 2 risk factors like prolonged rupture of membranes, pre-labor rupture of membranes, maternal fever, or 2 clinical signs like respiratory distress and cold peripheries, I may be justified to investigate and start empiric antibiotics. In the previous one, when red flag sign was there, it was a broad spectrum antibiotic. Here, it's only empiric antibiotics. But if there are only risk factors and baby appears well, then actually no antimicrobial, which is the end of the screen, is the best decision. But if I'm going to send a sepsis screen, I must promise myself that if the sepsis screen is negative, then I will not treat this baby. Here, I would like to share a quick story that made me believe in this. Maybe 15 or 18 years back, an IT professional father whose 35-weeker baby, like similar situation, was in our NICU. And he was very worried about the word infection and both antibiotics as well. Just like IT, he wanted both to go away. There should be no infection and no antibiotic also. He asked me, how are you going to decide whether my baby has infection? So I told him we are sending a CRP. He was very relieved. He said, doctor, so if the CRP comes negative, you will not give antibiotics to my baby. I was almost furious. I told him the decision is not going to be based on CRP. It is going to be based on the clinical picture of the baby. Then he asked me, doctor, if you are not going to base it on the CRP, then why are you sending blood tests for my baby? That question sunk into my head. I had no answer for him, but this is the question we all need to ask. My teacher, Dr. Saurabh, used to tell me that a clinical test should have 2 arms, positive and negative, and the responses of our clinical care should be different on both the arms. If my decision is I'm going to start antibiotics, then don't waste money and blood in doing any CRP or CBC. The nice red flag signs include signs of shock, evident shock, hypotension, prolonged refill time which does not respond to fluid management, tachycardia which is progressively worsening, high lactate, encephalopathy amounting to seizures, need for mechanical ventilation, a term baby, mind you. Preterm babies may get it for RDS, but if a term baby gets distress enough to get ventilated, it's a red flag sign. Respiratory distress starting more than 4 hours after birth. That means the first 4 hours, baby did not have distress. If it was early distress, one would think of transient tachypnea of newborn or respiratory distress syndrome. suspected or confirmed infection in one of the twins. One has culture positive, other baby may be started. Now, following this kind of a decision support system makes you not only legally safe, it makes you medically right. So if you're going to follow the NICE guidelines, these are easily available online. You make a form for the unit saying that you please tick if you have any of these red flag signs, you are justified in starting antibiotics. Tomorrow, if the parent or court asks me, why did my young baby receive a poisonous medication? We say this is a standard international guideline. Your baby had red flag signs and we had to be safe. What if your unit overinterprets this? There is no shock, but they make the baby look shocky. Many of our colleagues will do that. If they want to justify a therapy, they'll say, no, no, no. When I saw the baby's tachycardia was more, when you are saying it is less, it's all right. There is subjectivity in clinical, but at least let them fill a form. Let them tick a red flag sign before you start an antibiotic. What if this is not one I want to believe? I don't want to British guidelines. There are other sepsis scoring systems available. Many of you have seen, which includes various parameters. But in that, please focus on the last box, that is clinical illness. If there is persistent need for CPAP, HFNC, or ventilation more than 4 hours, need for oxygen to maintain saturation, hemodynamic instability, that is needing vasoactive drugs, neonatal encephalopathy and seizures, these are clinical illnesses and they are justified in labeling the baby as probable sepsis and starting antibiotics. Whereas only one sign, not two, lasting more than 4 hours, two signs like we saw in the baby with hypothermia and respiratory distress, a physiological instability like tachycardia, tachypnea, temperature instability, and respiratory distress milder than the next situation, not requiring oxygen, these may be indications for deciding. So you would have realized that the decision systems all over the world were independent of cultures or biomarkers. If you look at the standard textbook of Avery of Newborn, which was published 2 editions prior to this, has very clearly stated and accepted that we may never find a perfect culture or biomarker which will be there at the point when we have to take a decision on starting antibiotics. They almost bore down and said science will be always clinical, and when in doubt, when you have a sick baby in front of you, a clinician might depend more on his clinical judgment than on starting. But mind you, you cannot use this statement of mine to start antibiotic on a baby with TTNB. If he has only one clinical sign, wait at least for 4 hours. Or find 2 clinical signs for 2 hours, then also it's only equivocal. But if this baby requires distress enough to get ventilation, needs oxygen to saturate, needs vasoactive drugs, or has encephalopathy with seizures, we write, then no puristic approach, we give antibiotics. There are other clinical science decision support systems, like the European decision system, which includes almost similar things as the stops: temperature, cardiovascular, skin color, respiratory instability, abdominal distension, and then some lab signs. And they have said 2 clinical symptoms and 2 lab signs if culture is not available. Now the question we start on: why the Western world babies are so different that if they get a culture negative, they want to call it gold standard? And why in our low income countries, we are not able to trust this gold standard? Why is gold so different for us? I agree with most of your answers. Many sick babies in our country, when we do, have a negative blood culture. So next 10 minutes, we are going to spend on some practical points. And if you're using pen and paper, please use them as quality improvement methods. If they are going to be heard as a lecture, then believe me, we have heard this lecture ever since we started doing medical profession. Take enough blood, okay. Send it in time, okay. We've heard all this. But if you're not going to implement this lecture will just remain in this module for teaching. So one of the most important critical factor in deciding whether a culture would actually turn positive is volume of blood. We don't have to draw a bucket. 0.5 ml of blood for neonate is enough. And when we discuss in the further slides, there have been concessions for neonates and children. 1 bottle is enough. You don't need 2 sides, 2 bottles. You don't need a large amount. I'm sure we can draw 0.5 ml of blood. If you can get a little more to 1 ml, it might increase the opportunity of picking up a bug. On the right, you see a picture of a blood culture bottle. Please ask for pediatric specific bottles where the broth volume is reduced. The ratio of blood you take to the broth volume in adult, where you can get more blood, is 1:10 at the max. That means if it is 100 ml in the broth, you have to add 10 ml. Whereas in the newborn, it is 1:100. So if I'm having 100 ml in the broth, 1 ml would be an ideal amount at least. So smaller the broth in the bottle, I can get a better yield with culture, which is smaller in volume. So this is the first practice you're going to do. Second, we invert the bottle gently several times to prevent clotting, and we will see how even materials are added into the culture bottle to prevent clotting. Something we somehow have never developed a culture in our practice is to send all the details of antimicrobials that are happening to the baby. And the clinical details also, because suppose the baby has a central line and is 800 gramma, the same coagulous negative will be reported as sepsis. But if it is a term baby who has only TTNB with a nasal cannula, the lab will reserve its decisions and report it as a contaminant. So giving them clinical details is also very important. Now, the first quality indicator, I have to confess that I do not know exactly, because measurement is the first step to quality. Where do we stand in this quality indicator? Is that the needle, that means you're drawing the blood culture, to actual incubation in the lab. What is called as needle to culture time is the first quality indicator to make sure your cultures are turning positive. We know several times that the culture bottle leaves the lab, leaves for the lab. And the poor person who is taking the blood culture to bottle has many other responsibilities. Or the blood culture bottle is waiting in the lab, in the NICU itself, waiting to go to lab. The lab is understaffed, getting culture bottles from everywhere, and they are not able to incubate the culture. So if you need to improve, we will have to work as a system, not only as NICU and microbiology lab, on how we can improve this needle to culture time. Technology is all we want to work on. Sometimes we don't work on systems, but still technology does improve life. Additives are added to culture bottles. One of the commonly added additive is SPS, forget the expansion. It is an anticoagulant. So it prevents the blood from getting clotted and improves culture positive rates. Another additive is called saponin. It's a lytic agent. These two will be the most common additives you will find in blood culture bottles that help in improving the culture positive rate. There is sufficient evidence, and I have included a reference here. If one of you wishes to read this article and can't get access to full text, I'll be thankful to Sridhar to have shared this article to help my presentation to be more technically right. I can send it to you directly at the end of the presentation. I have not shared it in the module because it will violate publication rules of sharing articles. The other things that we add, very important information to young students, is that we add resins and sometimes charcoal, most often resins. You will find them at the bottom of the bottle, and their job, this latex resins, is to bind antimicrobial. So even if a baby is getting antibiotics, we often use an excuse saying the baby is getting antibiotic and therefore culture will not grow. But there are methods to what you can call is elute out these antibiotics into the culture body. through this resins. They will bind the antimicrobial. So you see the dissection of a culture bottle, you have broth. Now, why do we need broth? I can put the blood directly on an agar to see the colonies, but broth allows to incubate in an anticoagulated, not clotted culture medium, allow the bacteria to grow. So a broth is very important for bacteria to grow, amplify the bacterial load so that you will be able to pick up in neonatal situations where bacteremia rates are low. We talked about additives. Two additives we know, SPS, which is an anticoagulant. We also know that saponin is a lytic agent. We add resins to elute out antibiotics. There is a little bit vacuum on the top of the culture bottle so that when you puncture the cap, blood is automatically sucked in. The ratio in newborns is enough to have 1:50:100. This 1:5 to 10 is adult. So if I have 100 ml in the broth, 1 ml would be required to get a best result. And of course, it should be a type of bottle which you can easily puncture the septum to get the material in. I remember my lab quality systems blaming neonatal unit for overusing blood cultures, and we were shocked. We thought instead of blaming the medical ICU, which is not doing cultures but starting antibiotics without sending cultures, they are blaming the NICU for sending too many cultures. We thought they were talking finance, but only after reading the article which Dr. Sridhar gave me, I understood that we have to know, are we doing enough or too many cultures as well? If you're suspecting infection left and right, sending cultures when babies are probably not ill enough, then you would get a very low culture positivity rate. I think we are still there in our unit at this level, which means that I'm going to reduce the number here instead of 1,000. If it is 10 patient days, that means one patient in NICU may stay for 10 days. I should be sending one culture. If I'm sending 3 cultures for them, it may be too many. So how many cultures I send is a quality measure for patient days of antibiotic of blood culture use. And if I'm getting less than 5% positivity, it may not be only that the lab is bad, I may be sending too many cultures as well. Now, how long do I wait before I declare a culture is negative? Most bugs will grow, 98% bugs will grow within 2 days actually. There are some slow growing bugs, they may need more time. They need a more accurate environment. They're fastidious bugs, they don't grow easily. And therefore, labs give a final report in most cases only after 5 days. Although it is a true information that longer it takes after 3 days, the chances of contaminant getting reported is more likely. So if I get a culture positive on day 1, it is more likely to be true than getting on day 4. The next point we all worried about culture is delay. Now, how has technology as well as clinicians got around this? In low-income countries, you only have a manual culture, the algorithm line running below, where you send a blood culture. On day 1, the broth is shaken, and then we will see in the next slide how do we assess this broth. If there is no growth, they will check again on day 2, then on day 3, and if they have anything, they will plate it on the agar. And then the colonies will then be subjected to antibiotic sensitivity testing. We'll see all these in detail in the next few slides. From there, what used to happen in medical school when I was studying, these culture reports will hang in the lab and go to the NICU only when the Aya or the resident goes there or picks up the phone to call. And that time delay decides when antibiotics would be started. This process becomes faster in a hospital like mine, where I work now, where there is a policing happening, a quality policing that as soon as it is flagged on the culture, the lab has to pick up the phone, call the clinician, tell him, I'm telling you that culture is growing for so and so baby. Shall I authorize? If I say yes, the electronic medical record with date and time whom they have called is immediately entered. So if there is a culture positive and they have not called the clinician immediately, it becomes a compromise in quality of care and can have a penalizing action as well. Another smart clinician, a microbiologist in Bangladesh by name Dr. Saha, You can note down this name and read any number of publications by Dr. Saha from Bangladesh on smart methods of using cultures. What he used to do, he used to plate he used to put the blood culture into 2-3 bottles and then open the bottle and plate it on the first 12 hours, then 24 hours, then 36 hours. We must understand that when you open the culture and plate it, then a late grower cannot be picked up. But this way, he was able to pick up the bug at 12 hours by getting into 3 bottles and able to do the plating by first 12 hours itself. Even more important, he ensured that this report is informed to the clinician immediately. And he showed that he could get a turnaround time which was as good as those with modern automated methods in the Western world. In an automated method, the blood culture I'll show you in the next slide is being continuously monitored. As soon as the bacteria is put into the broth in a warm environment, it starts growing. And we know that every living thing produces carbon dioxide. We read it in biology. And this carbon dioxide is picked up by a detector. If it is there, immediately the bug is informed to the clinician and put into gram stain and culture plating. In a standard broth, how does a lab pick up? They will look for these changes. Either they will look for bubbles being produced, like in the picture B. They will look for turbidity, like in picture C, or they will see pellicles on the top of the culture or some small materials like balls at the bottom of the culture. If they see this, they say that they have found a growth. After this, we told you they had to plate it on the agar media from this broth, which was used only to amplify the bacteria this far to be able to pick up a bug. Now, smart technology is the same bottle contains both the broth and the agar, like this. And as soon as you see some changes in the broth, you just need to tilt the bottle like this, and the whole plating of the agar happens. So this reduces the processes, it reduces the time, and that's why you can speed up. So this kind of a bottle, although the cost goes up exponentially from a standard culture bottle to a commercially available broth and agar bottle like on the right side. We talked about automated methods. This picture was shared by my friend Anupriya, and she showed me this picture where the bottoms up of the bottle, this bottle you are seeing, which is on the right side, where in the broth, the bacteria are multiplying those dot things you're seeing. And as soon as they produce carbon dioxide, color change happens on the bottom of this bottle. So the colored bottle is having carbon dioxide in it, and a detector, a light detector, will immediately glow inside this rapid backed alert system. And immediately it'll say which bottle is glowing. You see the bottle number, call the clinician, and this detection takes only sometimes as less as 6 hours after the broth has been incubated. In the same incubator, you may have 10 to 12 bottles, 50 bottles, depending on the size of your hospital lab load. And then the right number bottle will glow, and you can call. Incubator can be closed again to continue the process. For antibiotic sensitivity testing, because most of us want to know not the name of the bug, we want to know which antibiotic is the best. So for this process, we need to have a antibiotic sensitivity testing. And in this, what you do, you have to plate the bug on an agar, which has various antibiotics as discs. You can see this disc here. And just like penicillin was discovered once upon a time, if the bug does not grow around a particular disc, that means that is a sensitive antibiotic. If another disc is there where bug is happily growing all around, that antibiotic is not sensitive. And the area of clearance gives you an idea on how sensitive the antibiotic is. Because as the area becomes bigger, the lower concentration of antibiotics would be there. Other methods like the gradient method in C can be used where a strip is used with lower gradient on one side and higher gradient on another side. So these methods finally give you the minimum inhibitory concentration. And this principle will be used when you are learning in the next few sessions that an antibiotic may not work at a certain dose, but if you increase the dose, it works. Certain antibiotics work at peak concentrations and certain on trough concentration like meropenem, if infused over a long time, will get a longer trough concentration, and that is a kill determinant. That's called time-dependent kill. And some are peak-dependent kills, like you give amikacin as a monotherapy, and you want to get a higher peak. So these would be principles used based on the minimal inhibitory concentration. Now, antibiotic sensitivity time typically would be culture grown in broth, then you put it in colonies on plate, then you put it on disc and look for. This will take almost 3 days. And for a clinician, this is just too late. Rapid methods may be from broth, you put it directly on the antibiotic plate. Don't wait for isolating colonies. These are rapid phenotypic methods where you actually see the colonies. And in genotypic method, what you do in standard methods which are currently approved or allowed is if you get a culture positive on agar plate, you take the culture and test for resistant genes, genotypic method. And currently we have just completed research where when you draw blood culture from a patient, same time you take a sample for studying resistant genes. The turnaround time is only 4 hours. So after 4 hours, the report would come to you saying that these particular resistant genes are there and these antibiotics are unlikely to work. So the typical methods of phenotypic method for testing where you dilute and then see how much dilution is required to kill. Diffusion methods, gradient methods like I showed you, and other methods are there. Molecular methods is what we discussed. By using PCR or a quantitative PCR, you can pick up which resistance genes are there in your sample. And in mass spectrometry, which is nothing special, you have heard of MALDI talk. What you're trying to find out is trying to solve the difficulties you have with PCR method. In PCR methods, you can get amplification and false positive rates can be high. How do you know whether this microbe is just there or it is responsible for disease? So in this method, what you can do, you can look for the dangerous proteins which can cause disease. So in mass spectrometry, all they do in MALDI-TOF is by using a laser, they will hit the colony, and when the colony is splattered, that is called time of flight. By the molecular weight, you can find out how far the particle has gone. This is a very oversimplistic description, and find out which proteins are there. So are you having those bad proteins which are responsible for disease or resistant bug? Now, other problem which we discussed during the initial part is certain blood cultures grow a bug when baby looks well. So how can you reduce the contamination rate? And the quality indicator is it should be less than 1%. In pediatrics, 1 bottle is enough. You don't have to take 2 bottles and 2 sides. Make sure you disinfect the top of the bottle very clearly. Teach the nurses yourself. They don't come ready-made. Culture bottles are available, but not trained nurses. So we'll have to train them. Make sure it allows the cap to be dry at least 30 seconds. It seems a long time when you start working before you actually puncture the blood into it. Having phlebotomy teams for culture has shown very clear improvement. That means you take these classes for your nurses, watch them doing it once, and then tell them, please continue doing it this way. That becomes a phlebotomy team. Having all the materials ready rather than running around for a needle, a cleaning swab, or a culture bottle, putting them all in a kit reduces contamination rate. Believe me, both contamination and infection are directly related to chaos in the urine. In babies, we don't draw blood like we do in adults where it stick in a needle and aspirate blood. So broken needle technique with a culture bottle open is a source for contamination. It is not acceptable. So put in a stick in a new cannula, and when blood is flowing into the hub of the cannula, like in the picture, you take a needle and syringe to aspirate blood. If you want to draw many samples, the first sample should be for culture. Clean the skin site with either isopropyl alcohol or chlorhexidine in concentric circles moving from center outwards. Please remember that you should not come back with the same swab to the center once again. You only move outwards and throw the swab away. If you want to clean once again, take a new swab, go to the center and move concentric circle outwards and throw it away. In extremely preterm babies, the difficulty is even if a few drops of this chlorhexidine flows from the puncture site downwards, goes behind the back, you will find extensive burns on the next day. So in our unit, we started using 0.05% of chlorhexidine, much lower for ELBW, and also ensure that you turn the babies back around after the procedure clean it with saline, and then only you leave the baby side. Some other clues may be there. If you get an unlikely bug that if you grow a cloacles negative staph in a term healthy baby on day 1, rather than giving vancomycin, please understand that this is likely to be a contaminant. Just send another culture, and if the baby is clinically well, wait for the second report. Now we'll interact with you. What is the wrong answer from what we learned so far? To draw a blood culture, I need to clean the skin correctly with the right material, concentric circles outwards, and I don't palpate the vein again after that to find out which is the vein. Once I have palpated the vein, I clean and don't come back to the vein, palpate the vein again. Use a needle and hub method. Take at least 0.5 ml or 1 ml blood, or despite of this presentation, I still feel there is no point in drawing blood culture. It is going to be coming negative anyway, and it is going to be too late. How many of you think, you can just think and probably not answer if you don't want to, that which is the wrong answer? All right, I think you would have found it, and it is a kaun banega crorepati type of question on the presentation. But I hope it in real life also, you will not go for thinking that there is no point in drawing blood culture from here on. It's a wrong answer. There is a great value besides just making publications that saying that this is the antibiogram report. Besides just knowing for the units database, there are other values of knowing this, and we will discuss that along way. So please start doing cultures, they're useful. Cultures are very sensitive. Even if you have 1 to 4 colony per ml load in a baby, a culture will pick it up. Or put it other way around, sometimes we say there were enough bacteria, we try to explain to parents, there were enough bacteria in the baby to cause disease, but not to be picked up by the lab. This is a totally wrong statement. If there are enough bacteria in the blood sample to be causing symptoms in a baby, they are sufficient to be picked up in a culture media. Does it mean that I am saying if I get a culture negative in a right method where I drew it by a cannula method after cleaning, I send the sample immediately to lab, they plated immediately, and they used an automated method, a rapid method, and inform me. A negative culture, does it mean there is no sepsis? You're right. It is very accurate. Negative predictive value is very high if the methods are correct. And 90 to 100% bugs will grow within 48 hours. And therefore, at 48 hours, if there is no growth, this is where the dictum comes of 48 hours. You should be bold enough to say that there is no sepsis. Antibiotics may be solved safely if baby looks clinically well. At least this much you should do. What if baby doesn't look clinically well? We'll come back to in the next 10 minutes. So quality culture rate, if you want to improve, if you really think you want to get gold standard culture like in the Western world, then look at positivity rate. Are you getting, if you're getting too many positives or too little positives? Too little means you're sending cultures for babies who don't have infection. Contamination rate should be low. Send enough volume of culture. I'm not going to go to technical details in research. How do you decide volume? Needle to incubator time. This is an area we all have to work between drawing the sample and reaching the broth. And in the lab for incubation, how much time? Time to detection of growth should be fast. They should inform the clinician quickly, that is turnaround time in the last row. Gram stain accuracy means they tell you gram negative and gram stain today and culture says gram positive tomorrow. This is not done. And antibiotic susceptibility time, how early do I get guidance on antibiotic are all standards for culture. I'm sure you are all waiting for the second part. And we will not spend too much time on this, but we will try to answer what we believe. The same baby, after 48 hours, culture has come negative. As you all thought, as you all see in real life, lab says no growth detected. But by now, baby has started new problems. He is vomiting and mild abdominal fullness. He remains active. Peripheries are warm, better than before, but baby's distress has not come down. Perfusion and sugars are okay. Now, with this distress persisting and new problems, I don't know whether these are CPAP-induced vomiting and abdominal fullness or it is new infection. You take a vote in your unit and it will be 51 to 49. Always, everyone supporting this. Let's start antibiotics. We'll decide later to stop, but we never stop it in real life. So, is CRP useful? Please understand a bacteria has to go into the baby, go to the liver, induce IL-6 and CRP production, and this takes time. We have had several times when babies were very sick and somebody had sent a CRP, it was negative. After giving antibiotics, after 48 hours, we found that CRP is 120 after 48 hours. Somebody repeated it again. So, a early CRP which is negative does not give you any information. And if it is positive, then you may anyway have started antibiotic based on the inflammatory signs. So when you're going to take decisions on starting antibiotics, don't waste money and blood on CRP. Take a clinical decision, and early CRP negativity gives no confidence to not start antibiotics. It is not a useful test to exclude infection in early course. A negative CRP, which comes after 48 hours, is reasonable confidence. So in the previous baby that we had, where 48 hours the symptoms were still there, at this time, if I have a CRP and it is some 3 or 4, believe me, we have to think it is only CPAP belly and not infection. We would be very bold to stop antibiotics. Some people try to find relevance that if CRP is decreasing or increasing in antibiotic decisions, but it is mostly discouraged. Hematological parameters, I won't go into details, but we all have learned that the total count, absolute neutrophil counts changes continuously. The values are very different at 4 hours, 6 hours, 24 hours, 48 hours. So unless you're plotting the hematological parameters on a chart of this kind with hours of life, you will get a very, very inaccurate value. It is for this reason the NICE guidelines recommend that first 4 hours of birth should not involve CBC at all. It is of no value. The normal values change not only with age in hours, but are different for different gestations. A high total count, which we learned in pediatric and adult of 20-25,000, is of no use. The red book we used to read for infections in newborns has even given that a baby crying for several hours can cause CRP to go high and leukocyte to go high. A vaccination can cause it, vitamin K can cause it, and therefore high total leukocyte count is of no value. A very low count indicates that bone marrow has been emptied and may be of use. Platelets can fall even by introducing a central line, hypothermia, and many other reasons, and therefore stop looking at low platelets to think that there is infection. IT ratio, very difficult to do unless you have a pathologist or a good lab, but even if it is done, it again has the same role like CRP, that after 48 hours, if IT ratio is normal, you get greater confidence in excluding. For those who are familiar with the word called big data and machine learning AI models, the labs try to pick up from the AI team tried to pick up 1 lakh to 2 lakh lab reports of CRP and CBC from the lab, from that Excel sheet of the lab, and connect it with cultures and media. And believe me, hundreds of algorithms were run. None of them could give a diagnostic model to utilize CRP and CBC to predict whether culture will come positive or not in newborns. So one line is the best current AI models with 2 lakh to 3 lakh samples is unable to find an algorithm saying that this blood count CRP combination, this CRP blood count timing, nothing is able to predict culture positive, and therefore it has very limited utility. Long back, my colleague Jamila, who is now in Bahrain, I hope she is all well there with this war going on. She had done a study where she looked at a new test that time, about 15 years back, procalcitonin versus what we use only stops as a test to predict whether sepsis would be better detected. We found no use. In fact, procalcitonin fared a little poorer. And the lab values of procalcitonin cutoff values, if you use very small cutoff values, almost everyone comes positive with inflammatory signs. And if you raise the cutoff value, it loses all its value. What we concluded in Jamila's study was, although it is known to rise faster than CRP, it was too expensive, did not add any value to our treatment. We don't do any procalcitonin in our unit for last 15 years after the study. It only added to the cost of the treatment algorithm. I had promised you that I'll mention something about PCR and IL-6, but I'll take that in the question answer session, and I'm coming to my last slide. After all this 1 hours of lecture, what should I do? How do I diagnose sepsis early so that I can treat a baby in time and not miss infection? How do I make myself a better doctor and I don't overuse antibiotics? I want to be a good doctor. Mantra number 1. Baby should have red flag signs. You don't have to memorize them. Download them either from EMA criteria, from NICE criteria, or if you can't remember, just our stops. And so if there is a baby who has seizures, severe encephalopathy, remains hypothermic and can't be corrected, severe respiratory distress getting ventilated, perfusion abnormalities requiring inotropes, sugars they don't correct with high GIR, all these are red flag signs. Even one justifies in keeping the baby safe. In this, your quality initiative should be, if I told start antibiotic now, within half an hour culture should have been drawn and antibiotic should be given. If there is no red flag sign, but I can't still settle down, maybe some abdominal distension, some lethargy, 2 clinical signs, if these in 2 different domains are there and persist for more than 4 hours, 6 hours, I may call them persistent sign in 2 domains, I think it's justified in starting antibiotics. Do draw blood culture. And I think the first one single focus I would ask you to do is to improve the needle to culture time, incubation time. Get the culture into the lab immediately. Second, if there is a culture negative, baby is not sick, then stop antibiotics. It is sensitive enough. But if the baby is sick, then after 48 hours, you may do a CRP. If it is less than 10, CBC not showing low ANC, then be bold, a IT ratio being normal, then be bold to stop antibiotics. A periodic audit of how your cultures are faring may also help you. So this is all I have to say. We'll be happy to have some questions from you. And this is something you're practicing every day. Like I made a promise in the beginning, there will be an effort to avoid biases and go by standard literature. But my bias is I do not like CRP and CBC when I start an investigation for a baby with infection. I do believe in cultures. And if culture is negative, it really takes an effort for my team to convince me on continuing antibiotics. So I'm stopping to share from here and we're happy to take a discussion. I'll hand over to the moderators of the session.
Excellent lecture, Naveen.
So, Manoj sir?
Yeah, please go ahead. I was
Okay.
just
No,
think of the
that's
stream
okay.
only.
So as usual, Manoj sir's lecture, like it's indeed a treat to listen to Manoj sir. Like I'm always happy to attend his lectures. Now, as being moderator, I'm forced to listen to lecture. But sir is like a very good teacher. Like I always admire sir. He's like a role model for us. Sir, shall we start some questions? We'll start with the questions. Manoj sir. Sorry, the Naveen sir.
Sure, dear Sunil.
Yeah. Now the first is like in babies with low or no apparent risk, but baby has poor suck, no risk factors, but baby has poor suck, vomits, high white cell count. Is it appropriate to start antibiotics pending blood culture?
Yeah, I think I would like to take the white cell count away at this point. That is very clear. I think absolutely clear. If you have wasted 1 hour with me today, please stop sending CBC and CRP when you are going to take a decision on starting antibiotics. Please don't send CBC and CRP at the beginning. It is waste of money and blood. So if this baby has a lethargy which can't be explained by hypothermia, hypoglycemia, resuscitation at birth, no other explanation is there, persistent encephalopathy is there, that I'll classify into 3 grades. A baby encephalopathic enough to get apnea and ventilated, especially a term baby, start antibiotics. Get persistent enough to put a tube feed he can't swallow, start antibiotics. But just he looks lethargic, wait and see whether one more domain sign is there. Put monitoring, talk to yourself, You can't convince yourself after 4 hours, you are the boss. Start antibiotics. But at least wait for 4 hours if there is no other clinical sign than one.
Okay, sir. Thank you. So sepsis is more for rule out the sepsis. Okay, so don't use these counts and for diagnosing sepsis as much as possible. Use them to rule out the sepsis. So next is Dr. Tejaswini is asking, sir, can we start and then later de-escalate in general?
Yes, you should. That should be the way if you are having red flag signs or two clinical signs. Remember that we love the baby more than the antibiotic. So if the baby is not looking well, I would 10 out of 11, I would start antibiotics if I can't convince myself. But the promise is there. Draw culture correctly, find it negative, baby is improved, stop antibiotics. This then, and one way to do is call a stop order.
Yep.
That is when you draw culture, when you write antibiotic itself, put a stop order out of 48 hours.
Yes.
After 48 hours, a nurse has to get a order again from you to continue beyond 48 hours.
Yep.
So when you do that, by default, antibiotics would stop unless you remember to restart them.
Yep. So what I do usually, sir, like just out of way, like in every patient in the round, I just at the end of the round, I'll ask, can we stop antibiotics? So that is a protocol. Can we stop antibiotics? So like then we can discuss all these things and clinically normal, culture negative, lab normal, stop it. Clinically, it's okay if you're started. So in the context of the twins, as one of the twin having signs of sepsis or risk factors, Dr. Jyoti is asking, what about DCDA twins and MCDA? Is there any difference?
I think that is just mentioned in the nice guidelines, but I think if the babies are just born and one of them has a culture positive, if the other baby is not looking sick, even then most babies we tend to start antibiotics, irrespective of mono or dichorionic, they have shared the same mother in any case. So we have 100 other reasons for starting antibiotics. This would be a surely a unsafe situation. If a baby is culture positive or symptomatic on day one, and other baby, I would start whether it's mono or di both.
Seizure as a red flag sign, maybe isolated, they want to say. Like Dr. Narayan, he's asking, like seizure as a red flag sign, he just, his doubt is the seizure as such isolated is a red flag sign? All seizures, please clarify.
Yes, in one way, even if I have hypoglycemia and seizure, even if I have asphyxia and seizure, there may be some 10% babies who had no similar symptom to tell me it's meningitis. Brain is important. It is a very dangerous sign. And I think in all red flag signs, you can't sit and say that this is, oh, I know this baby had asphyxia. That is why he's saying seizure. I might be too brave for somebody else's baby. Start. But again, promise that you will do CSF in 24 to 48 hours. And if you find no bug, then I will say this is not, and I will stop.
So like your answer, like it's there for this question also, it's answered like is birth asphyxia with seizure, do we need to start antibiotics? So again, same answer will be same. Dr. Rajesh is asking, I have 35 weeker with mild tachypnea requiring CPAP. Day 4 test showed leukopenia. Count is low, 3200 and platelet 67. Baby well. So not started antibiotic. Next day had vomiting and abdominal distension. Sometimes you have to take subtle clinical clue into account. He is right. So
Only
35
one,
weeker.
only one suggestion is in my unit, I would charge the money to the resident if he had done this in a mildly symptomatic baby. They know it. They're there around me. Somebody might have heard it. So if the baby is mildly symptomatic, both these tests are ill-justified.
Okay. So now he's saying that now he has developed abdominal distension now and in vomiting also.
Yes, this is very common,
Yeah.
and it is difficult to tease out whether this is CRP,
Okay.
I mean, this is CPAP or it is sepsis. I would probably, if these symptoms can't be teased out, you would be right in starting, but not because of the CBC or because of the
Hmm.
CRP. It's because baby is having
It
those
is,
symptoms.
can be just an non-septic also. Prakash is asking, is there need to send both aerobic and anaerobic cultures in newborn?
This is well answered in the article which was shared by Sridhar to me, that even though anaerobic bugs are there, the number in newborn sepsis is reasonably low. So I think the answer would be in one word is one culture bottle is
One
enough.
culture. TTN babies might need CPAP for more than 4 hours, but we don't start antibiotic usually for them.
Yes. If the rest of the stops, sensorium is good, euthermic, his perfusion is good, sugar is good, no antibiotics.
Can blood culture be drawn from central line? when
If it is
I
newly inserted, yes.
then Tanya is asking about what if we need to start antibiotics at night and we need to send blood cultures, but the lab is not accepting cultures at night due to short staffing. What to do then?
Yes, this is a true problem. I do not wish to say that you are asking for a wrong thing. We'll first repair our house and then fight with the lab people. So we need to really work on this together, have a coffee with the lab people together, and I'm telling you something will improve for sure.
Yeah. Sending two cultures from different site at the time for same patient. It's already
Not
answered, I think. Aaron.
not required in newborns.
Yeah. Which bottle will like specific bottle someone's asking has a higher yielding? Versatech versus Bactec.
I am not having the answer to the question in terms of company names, but automated bottles which are using resins to absorb antibiotics, which are using saponin and methods to improve the culture growth, seem to be slightly better. They are also actually slightly better, but their time to detection is faster because of the CO2 continuous monitoring. But detection rates are only shared better with automated methods than standard culture bottles. There, if you invert the bottle, send it quickly, it might give you the same detection rate.
What about sending central line or peak tip culture? PICC.
No, no.
In babies who are clinically sick and worsening, when initial cultures are normal with subsequent clinical deterioration with positive screen, and the blood cultures during this time still comes negative, how rational is to still repeat the blood culture for the baby?
Yes, you should repeat the blood culture because you think that the baby has a new problem. It might be fungus cons by now, and actually your detection rate is higher when babies are more symptomatic.
Betadine versus chlorhexidine for
Uh,
sterilization.
the- except Japanese, everyone uses chlorhexidine because of the worry of iodine causing thyroid depression in newborns, especially in preterms. But the Japanese have shown no difference between the two.
How to improve needle to incubator time?
Yes, it is a very important QI, and I think Manoj will help us in doing another workshop in QI methods how to take stakeholders together.
Duration of antibiotics in local infections with negative cultures like omphalitis, infected urachus, sinus, abscess. Duration
Uh,
of antibiotics.
we don't use systemic antibiotics.
Do we need to see decreasing CRP trends to stop antibiotics? If we
No.
have high CRP on day one with few clinical signs, what to do?
If you have so much money, please send it to me. I'll share my account number. Don't waste money on two CRPs. It is a
Now,
very old and very bad study. I need to tell you the Philip and White study, which talked about two serial CRPs. It is a very loud statement. Two serial CRPs to do the no infection and said 99% accurate was done in asymptomatic babies with CSF negative, culture negative, X-ray negative. Any Indian would find out that this is no sepsis without doing two CRPs. So read the paper, do a journal club, and you will realize that two CRP negative 24 hours is not required.
nowadays we are doing research studies on newer biomarkers. Should we stop doing so, as there is no so-called ideal biomarkers?
Yes, the biomarkers would get improved in many ways. Many of them are circumventing the whole processes of picking up only inflammatory markers. We are trying to study PCR for last 5 years. We have not reached the desirable outcome of the biological strength of actually picking up the microbe. We have found better detection rate, but we're still not able to say whether these are contaminants. This plus Malditoff may help you to know whether the poisonous material is also there. Some have used Malditoff alone, but I think the journey has to progress because we have to do.
What would if mother has prolonged rupture of membrane?
The longer rupture of membranes and pre-labor rupture of membranes. This everyone needs to know. Pre-labor means rupture of membranes have happened, but labor pain doesn't start for 2 hours. This kind was tested only in GBS testing actually. Very limited studies are there in gram-negative. Dr. Saurabh has done a publication on this, and if you read that, you will find that the risk ratio is very low for these risk factors. But even said that if the baby is born without symptoms and with these risk factors, and the baby is not sick, you may be brave. Canadian guidelines are there, which has stopped doing, like the AIMS protocol was there, that if it's less than 35 weeks, you test the baby even if he is symptomatic. The Canadians have stopped that. First 6 hours they would just observe the baby, They would not draw cultures or any sepsis markers in a risk factor setting if the baby is asymptomatic. The new sepsis scoring system also is saying the same thing. Unless the mother has more than 100 fever, a culture positive like GBS, if the baby is having mild symptoms, I showed that in the slide, then no antibiotics.
So, what is the role of CRP to start postnatal steroids in babies with evolving BPD? Is it safe to start if CRP is mildly elevated but culture is negative? Role of CRP in starting postnatal steroid in BPD. Is it safe to start if CRP is mildly elevated, culture negative?
I think it's a valid question. We do send blood cultures, CRP, and now these days even we do urine CMV also, in fact, before starting DART. We have had many babies where we started DART and they became CMV positive and they were negative to prior start with. So antibiotics, I mean, all these bugs might get multiplied. If I find a CRP of 20, I would rather try and treat a bug before I start a DART.
Okay. Sir, like how to interpret CRP in a neonate post-op? Most of them are high elevated CRP after surgery.
Don't send.
Okay. So sometimes a baby with asphyxia or MS has very high CRP on day one, and only there is a respiratory signs. Antibiotics are given after culture is drawn, but if after 48 hours cultures becomes negative and baby improves symptomatically, do you continue antibiotic or repeat CRP? No need. Or give antibiotics for 5 days or for clinical
No,
sepsis.
the first CRP also wouldn't be done, second also wouldn't be done.
Is a spontaneous preterm labor and an asymptomatic baby is an indicator for starting antibiotics? You already answered, sir, I think.
This is the only one where we'll be brave and not start antibiotics.
Yes. Single sensitive antibiotic monotherapy for culture positive sepsis, is it enough?
Yes, amikacin is enough. Please read the publication which has come from Abhishek Aradhya last month, and it has looked at a very large database of various centers, which has shown clearly that amikacin monotherapy has not only reduced, it is called a hit rate or accurate diagnosis rate. It is very high, and it is 80% sensitive. In fact, the Western world calls it a broad spectrum antibiotic or reserve antibiotic still. Adding ampicillin and cefotaxime is not justified in the absence of GBS in our setting.
Yeah. So clear message, take home message. Like amikacin is still like drug of choice, though you are very frank sepsis. Can we use cord blood for blood cultures if we suspect sepsis?
Yes, people have tried doing that. It reduces the number of blood losses, but I think we have to be very clean process when you're drawing, otherwise you'll get more contaminants.
If we have baby with highly elevated CRP with normal blood culture, is there any role to document any negative or decreasing trend of CRP before stopping antibiotics or duration based on the probable sepsis is enough? Based on the CRP, if we have highly septic casing, high
And
CRP.
we have had babies who had mild symptoms like a 26-weeker at 2 months of age and apneas have started, doesn't look sick otherwise. If you find a high CRP of 100, we'll look for fungal sepsis or a liver abscess after introducing a central line. So you would look for something else somewhere. In a mildly sick baby, preterm baby with central line earlier, look for fungal sepsis or liver abscess, renal abscess, and something like that.
How to go ahead if not possible to send blood culture timely?
Try to stain culture timely.
If we use BCG vaccine to a high CRP baby, any chance to increase the CRP again? And
No,
also want to avoid vaccine to no.
no. But
Uh,
intramuscular vitamin K can cause it to become positive. BCG may not be.
Kaiser permanente in EOS
And
calculator.
it has been not validated in our setting,
India setting.
but it makes good sense if you want to
Yes.
believe it. So the
We can
last part, that what is sick and non-sick, can be derived from that.
so we can modify, sir, for Indian hour scenarios. Uh,
Uh, we don't need proof in that sense, but we need to use common sense. So we need to use the algorithm and see that how they're trying to show that what is called as the likelihood ratio of not having sepsis.
Naveen, can I just add one point to that, please? Sridhar
Yes,
here.
Sridhar.
No, the Kaiser Permanente is heavily geared towards GBS cultures and GBS positivity.
yeah.
So it might be valid in institutions where GBS sepsis is high, but we actually, one of my PGs, Mintu's PGs actually did a thesis on that last year. And even here it showed that there was only 74% concordance with giving antibiotics. And there were about, I think, nearly 10% or 15% were missed cases where the baby actually had sepsis, where the Kaiser Permanente said not. So, like Dr. Sunil was saying, we possibly need to modify it, may not work in all
Yeah,
institutions in
because
India.
Sridhar sir, it was done in a very different setups, like good setups,
That
monitoring
is
was
true.
done properly,
Not only
and
that, their GBS is the main thing.
GBS was one of the risk factor for them. Like that was actually
Yes, that's
important respect.
that's
So,
right.
sir, like anything to be said about fungal sepsis, viral organisms like Klebsiella and Acinetobacter in ICU with baby worsening rapidly after 2 days. Anything to be said about fungal sepsis? I didn't get the question.
Okay, I'll
Okay.
probably answer that even though Delhi study and some others have shown fungus to be present in early onset sepsis, but I would still put my money if a baby was very small, if he has a central line, he has received an antibiotic, he is not improving after one good antibiotic, and he has severe thrombocytopenia and bleeding, abdominal signs, he has had an abdominal surgery by reaching the peritoneum. These would be some clues which would tell me think fungus. Second, on how many funguses are being picked up in the unit. When I joined my residency in PJ in 2000, they were having a fungal epidemic at that time, and it was actually that every other baby was getting fungus. So, if your unit is having very high fungus rate, your threshold should be lower. Otherwise, have at least these settings: a tiny 900, 800 grammer baby, central line, antibiotics, persistent bleeding, persistent abdominal signs, and so on.
Again, a very practical question. If sensitivity pattern is different and the baby is improving on the first line, should we change the antibiotic?
Most often, we don't.
If baby is has culture positive sepsis and we are unable to get CSF report due to trauma and the parents consent, then how to decide duration of antibiotics?
Tough one. We're just finishing a study. We tried to do CSF PCR because not only in trauma, even otherwise, we know that sugar, protein, cytology are totally inaccurate. And in the presence of culture, negative, because most often we do CSF examination on day 2, day 3, by the time babies has received
This is
antibiotics.
antibiotics.
But to be honest, a one-line answer is currently our study could not support enough. But it could only say that there were large numbers, 75% babies who were PCR negative. But this is not a statement for taking home, just letting know that people are trying to work in this direction.
Okay. Manoj sir, shall we continue? Like so many questions are remaining.
Uh, I have personally I have no problem, but
Okay. So we'll take few more.
I mean, like, yeah, I mean, like, 1.5 hours is a reasonable duration. So,
No problem. So
yeah.
last two questions.
Ask the faculty. I mean, if Dr. Naveen is okay for another 5 minutes.
Yeah, the cricket match is running very tight, but I can still answer it.
So two questions, syllabus, last two. So in HA babies with Doppler abnormality and repeated abdominal distension with line in situ and neutropenia and thrombocytopenia being a common finding HA, how to decide in this case?
If the baby is so sick, I would treat with antibiotics and wait for cultures.
Uh, Now there's again like preterm depression is a very common and show signs of shocks preterms. Should we consider it as a red flag sign and start antibiotic? Shock, preterm, depressed baby.
My incidence of shock is different from some of my colleagues, so it will be subjective. So there are many ways of diagnosing shock. If you want to treat, you will do echo and see something. You will do one refill and show something. So the threshold is different. But if you do have shock, it is a very valid or very important sign in predicting mortality and disability. So if a baby has a shock which is real, then I would rather treat than not. It's a red flag sign.
Okay. Akshay is asking, last question. Akshay is asking like how to decide which empiric antibiotic to be given if you decide to give one.
In the first antibiotic choice, we are using amikacin, and it works well most of the time. I am willing to take a difference of opinion, but this is what we've been doing for last 20 years. Piperazillin and amikacin are not hugely different, to be very honest. Please remember, piperazillin tazobact combination, Sridhar is also there in this meeting, is not a CNS antibiotic. If you're thinking of meningitis and encephalopathic baby, it is not piperazillin tazobact. Meropenem is a good choice, but if you're using it every day, your brahmastras will get over. So if you're using it, please infuse it over a few hours at least and use the dosing correctly. Make sure that meropenem has a shelf life of only about a day. You will be breaking a bottle every day. If you're using the same bottle for 7 days, the rest of the 6 days is water.
Okay. So, so I think I think we'll stop here. Abhay sir, like any inputs from your side? Abhay sir, we can't hear you.
Madam, you have,
Madam,
madam, you have to tell.
Thank you very much, Dr. Naveen. It's a very good class for me as well. And I'm very thankful to you because you have just reiterated about the clinical science. And it's not only the single clinical examination, but it's the ongoing supervision and ongoing monitoring of a baby to say whether the baby is going to have sepsis or not. Secondly, another this limitation of biomarker is very important, rather to start doing routinely, and the interpretation, because we have seen mild hypothermia of a late preterm baby can depress the WBC count. So these are very practical things, and you have already told us about the blood culture, because these contaminants, so the prevention of this contaminant blood cancer is very important in every NICU, because whenever the new residents join, we see there is a rise in the blood culture positivity with the contaminant. So thank you very much, Dr. Noin, for the practical tips, and it's very useful tips. So please continue.
thank you, ma'am. Thank you, Manoj sir, Naveen sir, Abhay sir. It was excellent opportunity to learn for all of us from you again. It's always we are lucky, like Manoj sir and Naveen sir both are very good teachers. And my personal, actually, I have very special bonding with both of them. So it's my pleasure always, as all delegates are saying they are appreciating sir's talk. So it's like it's always like pleasure to listen to Naveen sir. So thank you. Hope this discussion and practical tips, as Naveen said, like more of clinical, stop antibiotics as much as possible early, follow these rules. Biomarkers are actually like just don't use biomarker to start antibiotics just blindly. So thank you very much, sir. Chris and take home messages, very practical tips. Hope everybody will use it in their daily practice now, and it will definitely help decrease at least antibiotic uses at least. Thank you, Manoj sir. Over to you.
Yeah, thank you, Dr. Sunil, Dr. Sujanta, Dr. Naveen, and for a wonderful session, the second session. Now, I'd request all of you to continue to be part of this. So, the next, we continue with the dialogue of diagnosis and then go on to some rational antibiotic therapy and all with the next lecture that is coming up on Friday. So, until then, try to go through the resources supplied and then also do the posters for this to go on to the next lecture. So I would now request our coordinator, Dr. Abhi, to propose the vote of thanks and close the session. Yeah, Abhi.
I'm not prolonging. It's already 1.5 hours, and the number of questions shows that how sir has made the presentation so as simple as possible. And in one sentence, I would like to thank all participants who have come. We had almost 300 participants today, and that shows the enthusiasm. And thank you so much for attending. And please do the post test, and I shall communicate the rest through the WhatsApp group. Thank you all.
Thank you. Thank you.
Thank you.
Good night, everybody.
Right.
Good night.